Hi everyone, my name is Elayna Shanker and I'm a third-year medical student at New York Med. Thank you for coming to hear my brief talk. I'll be presenting a case report that I wrote on an interesting patient I encountered a few months ago. There is nothing to disclose. First, some background. Schizencephaly, the condition described in this case, is a condition of abnormal gyral development resulting from disturbances of neuron migration in early gestation. As a result of this failed cell migration, there is a gray matter-lined cleft in the brain extending from the ependymal surface of the ventricles to the pedal surface of the cortex. Classically, schizencephaly is described as either type 1 or type 2. In type 1, or closed-lip schizencephaly, there is a small cleft which is completely walled off by gray matter, whereas in type 2, or open-lip schizencephaly, there's a wider defect that is not enclosed but extends to the ventricle. Schizencephaly may be either unilateral or bilateral. It's typically diagnosed in infancy or early childhood during workup for recurrent seizures or unexplained delays. The clinical features of this condition depend not only on the number, size, and location of the clefts, but also with the type of variant, with open lip being more severe in many cases. A 21-year-old female with a past medical history of migraine-type headaches presented to the ED after a witnessed episode of rapid jerking movements, drooling, and profuse sweating. The patient did not remember the episode and was drowsy afterward. She slept through the night but awakened with a headache and non-bloody, non-bilious vomiting, which prompted her to visit the ED. She denied any past seizures or seizure-like activity. She described her migraines as occurring 2 or 3 times per week and lasting about 48 to 72 hours each. There is photophobia and phonophobia, but no aura. Ibuprofen provides minimal relief. Family history and birth history were non-contributory. There were no developmental delays during her childhood. Neuroexam revealed diminished sensation to pinprick and light touch on the proximal lower extremities, with sensation slightly more diminished on the right side. The rest of the workup, including complete blood count and comprehensive metabolic panel, were both unremarkable. 24-hour extended EEG monitoring revealed asymptomatic right temporal seizure activity. A CT of the head identified open-lip schizencephaly on the right, with possible superimposed periventricular leukomalacia adjacent to the right atria. The clinical picture of schizencephaly varies significantly, but so far, the literature suggests some associations between certain features and prognosis. For example, having bilateral schizencephaly is associated with more profound motor and neurological defects compared to unilateral. Similarly, larger defects, or those involving the frontal lobe, tend to carry a harsher prognosis. With so many anatomical variations within schizencephaly, there are understandable differences in case severity, with symptoms ranging from hemiparesis to refractory seizures to significant cognitive and neuro defects. Interestingly, our patient sought medical care only after experiencing her first seizure as a young adult. Although seizure disorders are the most common initial presentation of schizencephaly, these patients typically present before 3 years old. Our patient complained of frequent migraine headaches, but otherwise had no significant motor, cognitive, or social deficits. It is difficult to determine with any certainty why this patient's case was so mild compared to many others that look and measure up quite similarly on imaging. However, it's becoming clear that schizencephaly may be more prevalent than we previously suspected in the literature. With more neuroimaging being done every day and at earlier points in time, we may be able to identify other miraculous variants that have little to no functional impairment. Thank you so much for listening.